Well, thank you all for standing by. All participants are in the listen-only mode. After the presentation, we will conduct a question-and-answer session. And to ask a question, you may press star followed by the number 1. This call is being recorded. If you have any objection, you may disconnect at this time. And then turn the meeting over to Janna Petrock. You may now begin.
Thank you. Welcome, everybody, to today's webinar. We are able to present this webinar on behalf of the Mission Lifeline Stroke Project in North Dakota. I'm Janna Petrock, the Mission Lifeline Stroke Director. Very excited to be part of this project. We've been doing lots of great things over the last year, and we have 2 years left remaining on our project. And one thing we hear very consistently as we've been visiting with healthcare providers across the state is that there's a lot of questions and maybe perhaps even some confusion on the care of patients who are experiencing a transient ischemic attack. And as we always oftentimes call those mini strokes, but perhaps a warning stroke might be a more accurate description of this event. And I am pleased today to have Dr. Sachdeva, the interventional endovascular neurologist at Sanford Health in Fargo. So I'll turn things over to Dr. Sachdeva. You can introduce yourself and get started.
Hello, folks. My name is Gautam Sachdeva. I'm one of the vascular and interventional neurologists at Sanford. Welcome you all to the lecture today, and I'm going to talk about transient ischemic attack. And at the lecture, I'll be more than happy to answer questions. All of you can see the slide, and I'm just going to start since we are a little delayed anyways. So, like put in very well that a lot of times you hear that it's mini stroke. For the stroke neurologist, I do not like that term. The reason is because it kind of confuses people. A lot of people think that they've already had a stroke when that's mentioned. That's kind of not the reason. That's not the actual case. So it's really the definition is in the word, and we'll start with the definition and how the definition of TIA took place. So transient ischemic attack, right? So definition is in the word. Transient, of course, means transient. Completely resolves. That's why it's transient. It's loss of blood supply to the brain and attack. So this definition evolved. A lot of people say this still. If you look at the very first definition, it was a time-based definition. People said that it was an original definition was focal cerebral ischemia, event and the symptoms lasting like 24 hours. The definition in the mid-60s. So what changed it? As the image evolved, everything changed. What that changed is because people used to get transient symptoms and they used to get better in a period of 24 hours. And it's to be assumed that since the symptoms got completely better, it was a TIA. Imaging took place, especially in the MRI and the diffusion-rated images, to know that out of all those 24 hours, it was too broad because 30 to 50% of all those cases had some sort of diffusion-weighted restriction on the MRI. That means that those 24 hours, people suffered an event neurologically, but when you looked at the MRI of those people, once the MRI studies evolved, they had a stroke. So then, the American Heart Association, American Stroke Association, share from that definition of 24 hours because it was considered to be too broad of a period to describe, a transient ischemic event. So what changed? They brought a brief episode of neurological dysfunction caused by a focal brain or retinal ischemia with clinical symptoms typically lasting less than an hour and without evidence of acute infarction. It was around 2002, and again, it was not completely based. It was still time-based when they described it. It was less than an hour, but they also added that there was no evidence of infarction on the MRI. Evolved further, and the MRI studies evolved further, they could see some sort of ischemic hits or lesions on the MRI, which could tell them that it could be a stroke. So the completely changed in 2009, and this is the definition we follow till today. It's a transient episode of neurological condition caused by a focal brain, cord, or retinal ischemia without any acute infarction. It's a non-time-based definition, and this is what we follow today. In practicality, what that means is two criteria. If you don't look at just the definition, if you look at the practical aspect of things, there are two criteria. One is your symptoms completely resolve with any residual deficit, okay? The second is you do an MRI study and DWI or diffusion weighted image, which is the image which shows you an evidence of acute stroke, is negative. So those two criteria are used in practicality, but in definition, what it is today, which we use. So acute infarction. Now, the without acute infarction entails the MRI study, and it's mentioned directly, but that's kind of what it means. But see, we shied away. We moved away from time-based, and right now we are tissue-based. That's kind of where everything changed, and this is quoting the same article which was published in NEM, AHA, definition. That turn time was old, tissue-based is new, and to compare that it stays an episode of neurological dysfunction, which I just read to you, the same definition, with no infarction on MRI. What if no imaging is available? We'll say that we call acute neurovascular syndrome. Basically, prove that MRI could be positive or negative, because some strokes are silent, and some strokes actually, when they start, they have more elaborate symptoms, and when they evolute, and for the next couple of days, the symptoms improve. Even in the realm of this whole spectrum of TIA stroke, you will see that usually when people present, let's say if it's an actual stroke, people present with certain symptoms which get worse over the next 24 to 48 hours before they actually start getting better. And the reason for that is edema, which develops around a stroke. Coming to the TIA practically means that the whole gap symptoms resolved, nothing was there on MRI. And if you are a facility which doesn't have an MRI, and CAT scans usually don't show the stroke right away. CAT scan usually take around 12 hours to seeing signs of like white differentiation, loss of gray white differentiation, which practically means signs of an early stroke. So a facility which doesn't have an MRI, but your patient come in with acute neurological symptoms which completely resolve, CT is negative, still be able to call it an acute neurovascular syndrome if MRI is available. If MRI shows that there was a small stroke, then it's a stroke. Otherwise, it's a TIA. Ask me. The main question is, what's different? What are you different? If you ask me, this is actually your window of opportunity. There's a lot of similarity. There's a whole workup, and the whole etiology is not much different. It's like you're given a chance to work this patient up without actually patient having any damage, and you have the best window of opportunity to prevent any damage or prevent any catastrophic symptoms from happening. So that's kind of what a TIA is. Bottom line is, treat TIA should be as stringent and acute as if it's of an acute stroke. And I'll tell you, as we look down multiple slides, I'll tell you why. So again, do justice sometimes just to kind of put memory is important thing. So stats-wise, it has been estimated that 40% of the patient will have a stroke within the 90 days after the first TIA. Half of them, the first 2 days. So where the importance of doing the whole gamut of workup becomes important. And as we go further, I'll talk about which should be more likely admitted, and is it important to admit certain patients? And if you're considering an outpatient workup, how do you stratify that? So statistics say a lot. If you look at the numbers, like even if you consider 4 to 20%, that's a lot of patients, but 90 days. But if you break it down to 48 hours, half those, like around 10% of the patients, if you consider the maximum number, could have stroke within the first 2 days. Like I said, I do not personally like the term mini stroke, but I think this kind of put it into perspective that if you look at the TIA, so what's the difference? Why does the TIA not extend into a full stroke? So a lot of people have not seen physicians for a long time. All of a sudden, I've in my experience, I've seen this start in their 40s, early 50s sometimes that, why they've not seen physicians, things have been building up. And all of a sudden they have one symptom like vision loss in one eye, which lasted like 30 minutes, went away. So what that could be called a retinal ischemia or a retinal TIA. There's an artery called the central retinal artery, which is a further branch of the carotid. So what's that sign of is you need to look at the carotid, make sure the carotid was not blocked. So usually find in those cases is that it was partly not blocked, but partially stenosed. They go through it, but maybe during this flow, because of the friction amount of plaque, a plaque broke off, went all the way, and it got dissolved, and the symptoms went away. What difference? There's practically no difference. If you're experiencing a TIA versus a stroke, you do see that there's a temporary reduction in function in the same area. The only difference is the clot completely dissolved and the symptoms went away. In this case, it didn't, and it left an area of dead brain tissue, which we call a stroke, right? So practically the difference, it's not much difference otherwise. And that's a simple kind of differentiation between the both. Some numbers help us actually realize how big the problem is, which don't you realize otherwise. The incidence of TIAs in the United States has been estimated to be 200 to 500,000 per year, with a population prevalence of 2.3%. That translates to like 5 million individuals. Not small. Again, I've discussed this part that 10 to 15% of patients have a stroke within days, with the first occurring within 48 hours. I think this number is alarming enough. I've seen a lot of situations when actually people, I saw a couple of patients in the clinic today with exactly the same story, that right-sided numbness lasted like 2 hours. Completely also we thought we'll sit over it. 5 days later, they went to a outpatient physician who got a workup, and then actually it showed a stroke. So we do. How do we differentiate these people? How do we stratify that this could be admitted, maybe this patient has outpatient workup? So these studies have been going on for long, and as I go through the numbers, I'll talk about risk stratification. So stroke risk. This was published in Janna, the numbers I gave you initially, that 50% in the first 2 days. Lancet in 2006 had a publication by Rothwell et al., which showed that 40% of the strokes are put by a TIA or a non-disabling stroke. Stroke after a transient ischemic attack. This was a pooled analysis of some of the studies. 5% in the first month, 12 to 13% in the first year, 24 to 29% in 5 years. The American Heart and American Stroke Association on their website actually, the difference in numbers if you see, but they said that approximately 15% are heredited by a TIA, whereas some studies quoted 20 to 40%. Again, the power of the study was different and the population was different. And then between 7 to 40% people who have severe stroke have earlier warning signs. Where I see a patient with stroke, and I have asked them their detailed history, I always find that go back and some questions about did this ever happen before, and some or the other cue that something was going on. And that is usually going on in the first month or a couple months preceding the event. It's important to dive into the details when you see a patient is having symptoms, because maybe you have the option of catching that patient at the exact window of opportunity where you could have made a difference. I've sometimes vascular studies revealing high-grade stenosis in carotids, people present with these visual TIAs or hemispheric TIAs. People need this question, differentiate if it's a TIA or not. What are the signs and symptoms? What I put in there is what you see for every stroke, right? So there's much difference there. There's not much difference. Onset. The difference between stroke and TIA symptoms is not much in terms of initiation of symptoms. Everything is sudden. You see the word sudden mentioned with everything. Everything associated with stroke or a TIA is sudden. Sudden of stress or rest in one side of the arm, leg, even if it's temporary. That's the point. If you see, even if it's temporary, that's the definition of TIA. But the symptoms are not any different. Sudden onset vision loss, sudden onset trouble speaking, sudden onset headaches, sudden onset dizziness. At times, a lot of symptoms are labeled as, or a lot of patients are labeled as TIAs, but they're localizable. Say, when I use the word localizable, what I'm trying to say is, can you localize those symptoms to one vascular territory? What is the territory? Those cranial vessels like anterior circulation and posterior circulation. Anterior circulation is what? The carotid divides into middle cerebral artery, anterior cerebral artery, on the left and on the right. Anterior circulation, the cerebral arteries join to form the basilar artery, which basically provide blood supply to the brainstem, to the cerebellum. How do you, if you ever called one of us, regarding a TIA case, questions we ask is, okay, was one side more than the other? Was it right? Was it left? Was there any difficulty talking? Was there any gaze preference? So what am I trying to ask? Actually, am I trying to do when I'm asking you this? I'm to localize. I'm to localize it to one vascular territory. If you tell me speech was involved, I'm going to say, okay, I'm thinking left MCA. If you tell me that speech was involved and the right side was weak, it's right, left MCA, because the contralateral side is weak and the language is 90% of the time, the hemisphere is the left. Then if you tell me they are looking to the left, towards the side of their stroke, so that's gaze preference. So that I just did when I asked you. So I'm trying to localize it. So told me that the language trouble, they were weak on the right, and everything went away. So what does that mean? That means that this could be a left MCA, left hemispheric TIA. The symptoms are still persistent, either they're having an acute stroke. So that's practically the whole difference. I'm trying to make a point here is if you look through the slide, symptoms should still be localizable to one vascular territory, because the physiology is not much different. A clot is going up to the left MCA, causing the symptoms and dissolving. So let's come right MCA, right middle cerebral artery. What's the difference? Like left hemisphere control language, right hemisphere is responsible for neglect syndrome. If you have a stroke on the right, you'll be neglecting your left side, like it exists. But you'll have weakness on the left side. You'll have a gaze preference towards the side of the stroke. Now, if it's not a left, not a right, but small vessel stroke, there's a small vessel stroke. Coming in those very small vessels which are not visible to the naked eye, the lenticular striate arteries or the pontine perforators, if there's a clot inside them, you see either pure motor symptoms, pure sensory, or the ones I mentioned. And if it's posterior circulation, then you see more of incoordination, ataxia, diplopia, double vision, hemianopsia, those kind of things. So if you go through the slide clearly, this could all be TIA and this could all be stroke. The only difference is TIA is transient, stroke is permanent, but they should be localizable. Last, use this. And a lot of times these be coded as TIAs. It was a little slurred. They are confused. Loss of vision. Loss if it's like, eye, like a curtain falling in front of your eye, yes, that could be a stroke and incontinence. If you look at this, the reason non-focal is, I could put this one symptom into one vascular territory and say that, oh yeah, it's definitely a TIA. In fact, it's probably not. But you combine it with something, is confusion actually confusion or is confusion aphasia? Are they able to talk? Are they like frustrated that words are not coming out? But calling them confused because the best you could kind of make of it, that could be aphasia, that's localizable. Confusion, it could be UTI-related encephalopathy, it could be toxic metabolic encephalopathy, electrolyte imbalance, it could be anything. But the whole point of these two slides, what I make a point of this is to look for localizable symptoms, even if it's a TIA. Just something happened and it completely disappeared, not necessarily it's a TIA until you can localize it. You tell me they couldn't speak and they couldn't move the right arm, now they are better. Yes, completely, purely localizable TIA, it needs a full workup. If you had a little dizziness and that's pretty much it. It could be anything. It could be cardiogenic. Yeah, it could be neurogenic with vertebrobasilar insufficiency. That's a long shot. I explore other things before calling it a TIA. So non-focal symptoms, ones which are not clearly localizable, one vascular distribution. Physiology, what is the pathogenesis of TIA? Picture there. I could have used the same picture and said, what are the causes of stroke? Because that's different. TIA is practically three kinds: low, embolic, and lacunar. Now, distribute, if I go with the etiology of a full stroke, same thing. Low flow is because of stenosis, decreased flow to the cerebral hemisphere. Embolic could be because of cardioembolic AFib. Is small vessel disease, uncontrolled blood pressure, hypertension, hyperemia, diabetes, smoking. Large artery atherosclerotic disease is the major concern when somebody is having a TIA. What does that mean? That means that if transient symptoms and they went away and you bring a patient to me, my concern would be, let's do a CTA, let's do a vascular imaging to see maybe the carotid is blocked, maybe the carotid is highly stenosed. Maybe this is if you can see the carotid, maybe this is the picture, that's why they had it. Maybe this is how much the carotid is stenotes and I practically need to put a stent in. So that's what I'm trying to find out. That's the reason I want those patients admitted, because if they are discharged and practically they get a workup within a week or two, said let's get a carotid Doppler, what happens in the first 48 hours, like we discussed? 4 of the patients could have a stroke within 90 days, and out of them, percent could have it in the first 48 hours. So many go and they had a full stroke. That's quite possible. So these are not much different. Large artery atherosclerotic disease. Large are which ones? Carotid, middle, anterior cerebral. So the plaques in them, these are all large arteries. Cardio-aortic embolism. What does it mean? That means aortic-related. It is left ventricular thrombi. Multiple things. Aortic arch plaque. Anything could break off and go to any of the vessels. The embolism. Small artery occlusion. Like I said, not clearly visible to the naked eye, but this is where they are. Penetrating artery. Low striate arteries. They have little arteries, but they have clots inside them. And how did they form? Because of plaques over the years. Uncontrolled blood pressure. These are subcortical TIAs or strokes causes. Cryptogenic. I don't know. I had a 7-year-old female come into clinic today, and she presented with little talking, right-sided weakness. She's with her sister. They said it lasted like 45 minutes to 1 hour, completely went away. So what do you do for that? They did her. They did a workup. MRI was negative. She did not show any large vessel occlusion. Carotid stenosis. Happened. Something happened, right? Something did happen. So you already worked her up. Echo didn't show any low EF or any congestive heart failure. So what narrowed down to? It narrowed down to then an octogenarian who's an 87-year-old who had an embolic event, which was very clearly descriptive, but didn't see any large vessel atherosclerotic disease, so I ruled this out. A small vessel, she doesn't have major risk factors, so what did I narrow down to? Maybe it's paroxysmal AFib. She left with a loop recorder, and I totally agree with it. Why? It was just a TIA. Can you justify a loop recorder? Absolutely. You can. Because what was the etiology? It happened again, right? What was the etiology? Any atherosclerotic disease in the big vessels. We small vessel disease. Her echo was okay. So it came somewhere. Could have been paroxysmal AFib. And that's reason enough to justify that. So what I say is sometimes the workup is not much different. Sometimes the approach is not much different. You can do the extent of considering a loop recorder or something, and even with people with clear-cut hemispheric localizable TIAs. So physiology, again, it's kind of reiterating the same thing. There are main four processes. What happens is internal carotid artery stenosis due to plaques, atherosclerotic lesions, greater than 70% could be symptomatic. The number 70% doesn't always do justice. Even 50% could be symptomatic. TIA due to lesions of the vertebral arteries, which is the artery at the back of the brain, vertebral junction, basilar artery, low flow or embolic origin. Same with the stroke. Could be low flow because of the plaque or could be embolic because of the AFib or any emboli from the heart. If things out, and in a younger population, you could also consider dissection at the origin of the Peters portion of the ICA or at C1, C2 level. Kind of these are specific levels, but bottom line is dissection is one of the pathophysiologies, and dissection is an intimal tear, which can over the time develop a thrombi. There was an article published in 2017, and they compared TIA to unstable angina. And this is the spectrum. TIA with positive diffusion, which is a TIA, so it's not practically a TIA. It's kind of a stroke, but with fusion positivity, that's why it means the MRI is positive, and cerebral infarction. So you see unstable angina with troponin leak and MI. So that's the spectrum of comparison. And this recent paper published by Dr. Biller in 2017. Kind of a fair comparison, but TIA to stroke as unstable angina as to MI, near syncope, DVTs to PE. I don't completely agree with the DVTs to PE part, but again, unstable angina to MI is the main association here. Whatever it be, if it was not a TIA and you can't localize it, multiple things. Be hypoglycemia, which is also the commonest mimic of stroke. Be a migrainous event with scintillating scotomas in front of the eye, which patient perceived as some sort of blurry vision. Disease, which is MS, could be seizure, could be a tumor, could be other things, electrolyte derangements. So this is what you do. You do a CAT scan, MRI, you do imaging of the intracranial and extracranial vasculature. You do carotid imaging, intracranial imaging. You EKG, see if there's AFib. You can hook them up to a Holter, and you look at their echocardiogram. So you see there's no difference in this workup and the stroke workup. It's catching it on the right time and identifying the stenosis if it needs to be treated. Med Heart Association, these are class 1 recommendations. If you see class 1 level of evidence A and B for the most of them, patient TIA should preferably undergo neuroimaging evaluation within 24 hours of the onset of symptoms. MRI, including diffusion, is the preferred diagnostic modality. MRI available, head CT should be performed, which might be able to tell you if it's a hemorrhage or not, but in the 12 hours might not tell you if it's a stroke. Non-imaging of the cervicocephalic vessel should be patient. What does that mean? Look at the carotids, look at the vessels to see if there's any, atherosclerotic disease. Invasive testing of the intracranial vasculature reliably excludes the presence of intracranial stenosis. Invasive testing includes like a carotid Doppler, the cranial vasculature, but it's like a CTA and an MRA. That's the non-invasive imaging. In assessment, how do you do it? Carotid Doppler, MRA, CTA, depending on the availability and expertise. D should occur as soon as possible, and that's like a class 1 level of evidence B. Monitoring is useful in patients with an unclear origin after initial brain imaging. Nothing positive, you hook them up to a Holter to rule out a fib. Extrathoracic, at least, is reasonable in the evaluation of TIAs, especially patients who no other cause has been identified. To confirm transthoracic, like in PF with an atrial septal aneurysm, you'll need a more specific study like a TEE. The level of evidence for these two is 2A, but it's classified as one of the important workups to be done. Again, CT or MRI. How does it help in a TA? It could rule out a mimic. Maybe you're looking at a tumor. Maybe they had seizure-like event and had diffusion restriction from that. Maybe it was just an electrolyte abnormality. So MRI helps you stroke versus even rules out mimic. Cross imaging. Treatment. Within 2 weeks, 70 to 99% stenosis, 90-day risk of stroke is 25%. So that becomes important, right? If the hospital, and they didn't get an imaging until a few weeks, you wouldn't even know that there was a 70 to 99% which existed, which typically in today's day and age should be treated within actually 48 hours to 1 week is what they say if it's actually symptomatic. Put this guidelines. Now, who should I not admit? Who should I send home? Who should I send to the clinic? Who should I keep in there for observation? Very good question. So over the years, they came up with these stratification scores. The one was a California score. They used to call it California score. So diabetes, TIA lasting less than 10 minutes, weakness associated with it, speech impairment associated with it. They came up with this ABCD score, and at present what we use is an ABCD2 score. What does that mean? That means whatever it's described here. Age more than 60 gets 1 point. Blood pressure more than 140/90 gets 1 point. If it's unilateral weakness, one side, right side weakness, that gets 2 points. If it's speech without weakness, that gets 1 point. Duration symptoms is important, 10 to 60 and more than 60, and then diabetes. So if you look right there, that is stratified the script. Low is 0 to 3. 2 days, percentage of stroke after TIA is 1.2, 3.1. And as you go higher with the score, you see there's a risk going up to almost like 18 to 20% 8 days. Now, think is missing in the ABCD2 scores. You see any mention of imaging. So that's where it lacks specificity. It's a good score to help you stratify where the risk stands, but still don't have an imaging criteria because say the symptoms resolved and you quantified them as this and you don't have an imaging. So even if you don't have an MRI, you don't even know if they had a small stroke, which has become silent. So what this kind of a modification of it, AB2 plus I, which is an image, and if there's an acute infarction on diffusion, they added 3 points to it. That's practically a score which is used, the ABCDI, but if just considering the ABCD2 score, which is still used a lot, and it still gives us a decent amount of information and who definitely warrants admission, it doesn't give us the imaging characteristics which actually help in making decision one way or the other. What initially was followed with the ABCD2 scores, 0 to 3, stroke risk is close to 1%, and hospital observation may be unnecessary without another indication. I, as a stroke physician, kind of do not agree with that statement. That is that we don't have a vascular imaging supporting the score, which carotid Doppler or a MRA or a CTA to tell me. I haven't been in, like, to hook up tele enough to tell me there was a new AFib. So my bias, like every patient who has an acute onset of a nerve deficit should practically be admitted for at least a full workup in the first 24 hours. In cohorts, the two-day risk of stroke was 0% for stroke scores of 0 to 1, 1.3, and then all up to 8.1. This is an important line which I wanted to make a statement for. The risk of stroke on MRI diffusion is associated with a 2 to 15-fold increase in subsequent short-term risk of stroke. So where my bias comes in, that if there's vascular imaging and there is no diffusion-related imaging supporting the score, it does help you stratify. It helps you rule out, it's like the negative predictive value is high, that you know that these patients definitely make a case of being warranting admission. But if you look at the MRA numbers, there is, okay. I'm being told that I have 5 minutes for questions, and I'm going to skim through this. I'm going to just skim through the last two slides. Who should be admitted? These should be definitely admitted. No prior vascular imaging, risk factors, ABCD score of 3. Recommendation, first TIA, less than 24 to 48 hours. Generally recommended crescendo TIA is like, symptom occurring again and again and completely resolving. This is more than 50%. Stratify the general risk in terms of platelets, anticoagulation, risk factor modification. Turning points, often health professionals and the public consider it benign but regard strokes as serious. These views are incorrect. Stroke and TIA are on a spectrum of serious condition involving brain ischemia. Both markers of reduced cerebral blood flow, increased risk of disability and death. However, offer an opportunity to initiate treatment that can foretell the onset of permanent disability injury. Some a mini stroke, but it's really a major warning. 911. Some opportunity to prevent a catastrophe. Don't lose this. Act. But I finish my presentation. I'm open for questions.
And we will now begin the question and answer session. And if you'd like to ask a question, please press star followed by the number 1. Once again, that will be star followed by the number 1. Please unmute your phone and record your name clearly when prompted. Your name is required to introduce your question. And to cancel your request, you may press star followed by the number 2. One moment, please, for the first question.
I do have a question here, so I'm going to take it from the gentleman here. Yes.
Let's say patient is on aspirin,
right,
something with the TIA.
Right.
Would you necessarily change the antiplatelet agent at that time?
Not necessarily. The question was that, let's say the patient was on aspirin and the patient came in with a TIA. Would you change or switch the aspirin? It's a very good question, and we face this a lot. I'm going to back to my slide of what could have been the etiology of the TIA. So like if I thought that it was a lacuna TIA, lacuna TIA means that there was just like pure motor, pure sensory motor symptoms. A trial, which was CHANCE trial, which was done in China, which extrapolated to U.S., which said that if you add dual antiplatelet for 21 days, it could be beneficial. Maybe we'll proceed that route if I think the etiology of the TIA was lacunar. If I think it was hemispheric, like it was like cortical, okay, the etiology of that could have been, something like a fib, something cardioembolic source. So I'll explore the source. I'll do a whole workup, but not necessarily change aspirin to anything else. Aspirin provides like 30% protection. Doesn't mean that if somebody has a stroke on aspirin, they fail aspirin. So not necessarily. I think variable on case to case. What could have been the etiology, and the court could add something or not change anything, or maybe change something. Let's find a AFib in that person. I might him to an an oral anticoagulant, if they don't have coronary artery disease, if you have it, then I'll keep them on a low dose aspirin and add an anticoagulant. Makes sense? Yep. Okay.
Questions?
Speakers, at this time, we don't have any questions on queue. Once again, participant, if you'd like to ask a question, you may press star followed by the number 1, giving it a few more seconds for questions to queue up.
One more question in the room here in the meantime.
Yes, to the first question. The good and the bad of dual antiplatelet agents in this type of deals. When he's on aspirin, they get a stroke. Plus and the minus of dual antiplatelet.
In which type of deals, though? What kind of?
Patient on aspirin gets a stroke.
Get a stroke or a TIA?
TIA.
Okay. So there are only few conditions in neurology or in the stroke world where antiplatelet is justified. Apart from that, it's by case basis. So what are the two? One, I mentioned the chat protocol. What does the protocol say? That if the ABCD2 score was 4 or less, for TIA, NIH stroke scale was 3 or 4 or less, you go antiplatelet for 21 days. Okay? So that's one. Number two, it's if it was the Sampras trial, which said that if there is static intracranial atherosclerotic disease, that if the MCA had like stenosis, symptom, but they completely resolved. If you're asking about TIA, let's say they completely resolved, and they're aspirin. If adding dual antiplatelet for 90 days for those people. Okay, down is just like any other blood thinner. Like there's more chances of bruising, more chances of bleeding. If age is like octogenarians, they fall, they suffer. We've had subdurals develop in those people, so those risks do exist. But it's very case by case. For me to put somebody with a on dual antiplatelet, I need to have a clear understanding of what their etiology was. The two situations in which I would use dual antiplatelet, in even TIAs or even strokes.
Great questions came up.
If you don't have questions, thank you. Once again, that will be star followed by the number 1. Speakers, you may proceed.
There aren't any questions at this point. Dr. Sachdeva, we greatly appreciate you having us join us today. Great information. And we're planning another webinar most likely in September that we hope you all can join as well. And this webinar has been recorded and will be sent out to all of you, as well as other healthcare providers across the state. So thank you very much.
That's today's conference. Thank you all for participating. You now disconnect.